Hello, everyone. Happy to welcome you to today's webinar, where we'll be discussing what happens to telehealth after the public health emergency expires on May 11. My name is Vladimir Negron. I'm the head of demand here at Mend, and I'll be your host for today's webinar. Today, I have the privilege of joining Matt McBride, president and co-founder at Mend. How are you doing today, Matt?
Doing fantastic, Vlad, and I know we have another huge audience and a lot of important, I think, valuable content to go through today. So very excited to be here.
Excited as well. A quick disclaimer before we look at today's agenda: the presentation does not constitute legal advice, so please consult your legal counsel, compliance and/or billing resources before taking anything that's discussed here under consideration. So to start out, the Biden administration recently announced that the PHE, or the public health emergency, will end on May 11, which is just about 2 weeks away. We're going to start today's webinar talking about what expires the next day on May 12, which policies stay in effect and which go bye-bye. Then we'll spend most of the time reviewing the DEA's proposed rules around prescribing controlled substances utilizing telemedicine. And finally, we'll round out today's webinar with a Q&A session. Starting now, you can use the Q&A box at the bottom of your Zoom toolbar, and we'll get to as many questions as we can at the end. Matt, I know you absolutely love what the Center for Connected Health Policy, or the CHP, does, so much so that you've plugged them in numerous past webinars. Can you explain what is the CHP and why they're especially relevant for today's topic?
Yeah, absolutely. And the website is there on the slide, so feel free to jot that down: cchpca.org. And they are a great resource. They have a great email distribution list. The website is a great resource, especially if you're looking for state laws. They've got links right to the exact statutes. They discuss anything related to telehealth. So anything you might need to look up from a policy perspective, maybe different legislation that's been introduced in the state, what is actually law, links to it. All of these things are there. So I think it's a great resource to stay on top of everything that's happening in and around telehealth. So definitely jot that website down.
The U.S. federal government has been busy over the last year, and that's probably an understatement, making numerous changes to telehealth, telemedicine policy. Matt, can you take us through a timeline on some of these key highlights?
Yeah, absolutely. So we have early last year, we saw the first extension. We saw a 151-day extension for most of the waivers during the public health emergency, not all. And we're going to discuss the ones that aren't included. We then saw, as we do towards the end of every year, but in particular in recent years, as the final physician fee schedule comes out, there's a lot of different clarifications in there around telehealth for all sorts of things, to new codes that are being tested, codes being proven out, all sorts of things. So we saw that, and so that means there are some pieces that right now only go through 2023. Then we saw the 2024 extension right at the end of last year. And so most of the important waivers have been extended through 2024. Not all, because there's still a couple that are dictated by the end of the PHE, the 151-day extension, the physician fee schedule, so on and so forth. We got the last extension to the public health emergency in January of this year. shortly after the Biden administration announced, as they said they would give everybody at least 90 days notice. And we saw that they were making it official that the public health emergency would end on May 11th. Now, we have covered a lot of the intricate details on what, stays for 151 days, what goes through 2024. We did cover that in a past event, which we'll touch on at the end of the presentation today on how you can review some of those materials. So a lot is been going on and is still going on, as you'll see in the presentation today.
Matt, let's jump into a time machine, if you will, and pretend like we're going to May 12th. A little fun. What's your preferred mode of transportation for a time machine? A DeLorean or a TARDIS to get you there? And what should we be expecting with the expiration of the COVID-19 public health emergency?
Yeah, we'll try the DeLorean. I think they always seem to make it back, so I do want to get back. So there's some important things to note for May 12th, and also some breaking news and some things that haven't been totally finalized yet. So first, we have the use of non-HIPAA compliant communication, which we've been covering in lots of different past webinars, that was not going to be extended. That has pretty much come to fruition because we do have some good news to report. I was reading yesterday, very early in the morning, the Associated Press, or actually this was in another article that came out, I believe last week, that providers are being granted a 90-day extension to get into compliance. So to move to a HIPAA compliant solution, to phase out, Facebook, WhatsApp, all of these FaceTime, these non-HIPAA compliant solutions that have been used. You've got 90 days following the conclusion of the PHE. So starting on May 12th, got 90 days to move everything over. The other piece is the prescribing of controlled substances without an in-person exam. Now, when we covered this in February, there were a lot of questions around this. So we're going to talk about the details of number 2. So we'll get into all those details. And then we have the end of basically any sort of co-payment types of waivers. Maybe a copay was being waived, or other types of discounts, or deductibles, anything of that nature. That ends on May 11th. And then also relating to RPM services, that will resume applying to only established patients. So there was a waiver in the public health emergency for remote patient monitoring services to be offered to new, or really any patient that needed it. That will move back to established patients. So these are the changes coming in just a couple weeks.
Matt, we've referenced it, or you've referenced it a couple of times during our February webinar. There was a lot of questions about the DEA proposed rule for telemedicine and how it impacts prescriptions. Before we get into those details, let's do a high-level overview on the subject.
Yeah, absolutely. So we're going to spend the majority of our time here today, pretty much all of our time here today, because I think there's the most is happening, and this, I think, has the greatest impact to a lot of different organizations, especially a lot of our customers. So so let's just briefly go through this, and then we'll start diving into some of these details. So if you're seeing the patient in person, you can prescribe whatever you need to. If you are going to utilize a telemedicine referral process, you can prescribe whatever you need to through telehealth. We're going to dive into how that was defined in the proposed rule. If you haven't seen somebody in person, and it's schedule 3, 4, 5 or buprenorphine, then you can write a 30-day prescription. And this could be one of the areas that'll change, and we'll talk about that later in the presentation. And then for schedule 2, just right now, the proposed rule says you really can't do anything through telehealth. This it could change as well. So we'll talk about that and some of the comments that have been made to the proposed rule. But at a high level, this is a pretty good summary of what is going into effect.
So based off of what I'm hearing, the rule isn't final yet, right, Matt? And if it's not final, when should we expect to see the final rule?
Yes. So shortly after the Biden administration announced the conclusion of the public health emergency, the DEA proposed the new rule. There was then a comment period that went for roughly 30 days and ended the end of March. So ended last month. So we're not even a month into the review of the comments. And there were a lot of comments. So we're talking about 35,000 comments were submitted. We, MEND, signed on to some letters through some organizations that we're involved with from a policy perspective, but 10,000 comments were delivered in person. So that's, patients are making themselves known. A lot of organizations are making their voice heard in this process. So maybe we'll see some changes. So now we're waiting for the final rule. And I just happened to read yesterday, early in the morning, that from the Associated Press, that the HHS and DEA are working together to finalize a rule by May 11th. So this always tends to be the case, use every second possible. The government always seems to, at the very last minute, provide the stuff when we had the entire time during the public health emergency to work these things out. So we should see the rule by May 11th. Now, they also said that the new requirements would take effect in November. So there may be an extension, there may be a grace period here. This was a quote taken, so there weren't additional details. It could also be in reference to the 180-day period of patients that you saw during the PHE through telehealth. You can still continue to see them. So it could be related to that. So we'll cover the 180 days. So I think, just to reiterate again, it was in the news yesterday that we would see the final rule by May 11th, and we could see an extension period through November.
In addition to the in-person requirements, there were several other changes proposed. Matt, take us through what you see as the summary points that everyone should be aware of.
Yeah, so these are the other sort of details covered in the proposed rule. And so we're going to dive into each of these in a little bit more detail, but we have the in-person requirement, which I think everybody is the most familiar with, because that's the one that potentially creates the most disruption to an organization. Then we have this term around a telemedicine prescription, and designating certain prescriptions as a telemedicine prescription. But I just want to point out that this is not for anything, anything and everything that's prescribed in telehealth. That relates to certain situations where it's virtual first, they haven't been seen in person yet, and you're giving a 30-day supply, or you're going to use the telemedicine referral process. So just make a note of that. You don't have to designate a telemedicine prescription for every prescription through telehealth, just in those two situations, which we'll cover in a little bit more detail. The last two are really pretty simple. They're really just aligning with Medicare and laws and guidance that's already been put out there and commented on and finalized. So the definition of telehealth has been aligned to Medicare's definition, and then what Medicare has already allowed for audio only, and exceptions for treatment in mental health. So the audio only that's allowed in mental health, and exceptions for treatment in mental health disorders. They're just aligning with Medicare on those. So those are the main highlights of the proposal, and we'll be diving into some more details of these.
Matt, during our February webinar, we mentioned that a large number of the audience asked if existing telemedicine patients would be grandfathered in. What do you see is in the current proposed rule?
Sure. And just a quick side note, I'm already seeing a number of questions. Will we get the slides after? We're going to get this. We'll get the slides out to everybody. We'll try and get all of the materials out that we discussed, plus some additional materials. So we'll cover that at the end. But we will, as we always do, we make the materials available. We record it. We'll have the recording available. So don't feel like you have to take a ton of notes. We'll make the materials available. So yes, so we have this 180-day extension period. So what does that mean? What's covered? A question that came out in our last webinar, and that we've seen is there grandfathering? So no, there is no grandfathering. I think grandfathering would apply that anybody that you treated through telehealth during the PHE, that you would be able to just continue that forever. And that's not what the DEA seems to want to do. So they've called it a 180-day extension period. So let me just, for this slide, I'm just going to read my notes just so that I don't miss any details here. And we get everybody, as accurate of information as possible. So the proposed rule introduces the concept of a telemedicine relationship established during the COVID-19 public health emergency, which grants a 180-day extension for the in-person exam waiver. To qualify, practitioners must have prescribed a controlled substance based on a telemedicine encounter without an in-person exam during the PHE period. So this would have been from March 16th, 2020 through May 11th of this year, just a couple weeks away. The 180-day extension does not apply to new patients after May 11th, 2023. So will the final rule, we may see that extended through November based on what the Associated Press put out. Otherwise, this may be what they're referring to. So it's one of those things, maybe hope for the best, prepare for the worst. Be prepared that you may need that in-person exam starting on May 12th. It says the extension applies to Schedule 2 through 5 controlled substances in all areas of the United States. Practitioners must either conduct an in-person exam, meet another telemedicine exception under the Ryan-Haight Act, or stop prescribing after the extension period ends. Now, a lot of folks may have perked up. Oh, there's exceptions. We're gonna cover that next. There isn't great news to report there, but definitely something that we'll cover.
Well, let's you teased it, Matt. Let's cover how they're defining exceptions, because it does seem kind of like a gotcha, right? What's referenced actually in the Ryan-Haight Act?
Yeah, I mean, is there a loophole, a workaround, or something? So far, not that we can tell. So these are the 7 practice of telemedicine exceptions in the Ryan Haight Act. So you've got treatment that happened in a hospital or clinic. So you've got the in-person care that happened essentially, treatment in the physical presence of a DEA registered practitioner, again, sort of in person, treatment by Indian Health Services or tribal practitioners. So that there's definitely some exceptions there for the groups that fall into those categories, although most of us don't. You got treatment during a public health emergency, which we're in right now. Treatment by a practitioner who has obtained a special registration. Again, I think a lot of people just perked up. There's a special registration. We're going to get into that. Treatment by Department of Veteran Affairs practitioners during a medical emergency. So that could affect a lot of our veterans, maybe in a good way. And then you've got other circumstances specified by regulation. The other circumstances is what we're talking about. This proposed rule that will become a final rule sort of falls into that 7th category there.
This is a good time, Matt, for a little bit of a break in the webinar. Let's take a quick audience poll, and I'm about to launch it. It should be on everyone's screen now. So the question is, how likely will the DEA proposed rule have a negative impact on patient care within your organization? And the choices being no impact, some impact, or high impact. We'll give a minute for everyone to answer, and once everyone is done, I'll share the results and we'll continue with the webinar.
Vlad, actually, the poll question is asking about percentage of visits that are virtual.
Well, that is interesting. All right.
Maybe that was a technical.
That's a technical glitch on our side, so we apologize. We are seeing people obviously answer this poll. So Matt, we'll cover the results of this poll just in a few seconds. There's some people still answering this poll.
Well, if you're doing a high amount of virtual, there's probably a high amount of impact. So
I would guess so. All right, we're gonna wrap it up. Matt, what I'm seeing here, probably not very surprising to you, percentage of patient visits within your organizations that are virtual today. We're getting a large portion, about over, sorry, I'm doing some quick math, 30, 50, let's say over 60% of people are saying that their percentage of patient visits are anywhere from 26% to all the way to 100%. The greatest of those being between 26 and 50%. So not too surprising, but I don't know, Matt, if you have any insights that you want to share with the rest of the team and how it relates to this webinar.
yeah, sounds like there's a lot of potential impact, which I think we've heard and as we saw and questions around this. So yeah, let's get into the rest of it. I think we've got a lot of other great information to cover here.
All right, let's get to it. Matt, we were referencing before the exceptions, and looking through them, I have some questions about exception number 5. We had talked about describing a special registration. Does the exception even exist? What are you seeing based off of all of this?
Yeah, so I think as we were going through the 7 exceptions, and this was a place where maybe people perked up, and it's kind of unbelievable what has taken place here. So let's just go through the timeline real quick. So um, the these exceptions were introduced. These 7 were introduced back in 2008. The DEA made reference to maybe creating the special registration for telemedicine, and this is well before the pandemic. Here we have a government agency maybe being a little proactive, and already starting to think and talk about telemedicine, but it never really they didn't do anything with it. So fast forward 10 years elapsed. 2018, the Support Act mandates the DEA to activate the special registration by October 24th, 2019. So again, this is before the pandemic, right? We could, the government, Congress, the president, they act, they say that the DEA, you have to activate this, right? Just like months before the pandemic began, and nothing. So there was a deadline. A deadline came and went, and the DEA did nothing. They did not publish anything about the special registration. And so now we have this proposed rule that came out in towards the end of February, and they're saying that, oh, this rule satisfies our requirement under the Support Act. So we think the special registration creates additional burden for telemedicine providers and patients. This satisfies our requirement. And so, it maybe we'll see it with the amount of comments, but we may never see a special registration for telemedicine. So it's not an option as of yet. So there aren't a lot of great exceptions to try to pursue beyond what's covered in the proposed rule.
Matt, so if the special registration is unlikely to help, what about the qualifying telemedicine referral process?
Yeah, so this was a question for the big question coming out of the event that we did in February around the conclusion of the public health emergency. So this is the best option. Really, the only option that we've seen is to have some sort of in-person scenario where the patient can come in person to your organization, and then do the rest of the visits virtually, if that's the best course of action, or you can establish a telemedicine referral process with another licensed practitioner. So you can refer. It has to be a written referral. This is something that you would definitely want to consult legal counsel with around the documentation for this. The special registration was too burdensome, but this is not. And this does have a lot of documentation requirements for both the refer and referee. So you would definitely want to look into that. So you could refer, then you could have telemedicine by the second practitioner. Another thing to note here is, depending on what you're prescribing, the telemedicine practitioner needs to have access to the prescription drug monitoring program, because you'll see on the next bullet point, controlled substance prescription. If they don't have access to that database, you are limited to only a 7-day supply. So you got to have access under this telemedicine referral process. You've got to have access to that monitoring database. And then this is one of those situations where the prescription has to be designated as a telemedicine prescription. So again, we covered this earlier. There's only two situations. You have this referral process in place, or it's a virtual first encounter where you're giving that 30-day supply, or whatever the final rule says there. And then, as I already kind of alluded to, there's a decent amount of documentation and record keeping that's spelled out in the proposed rule. So it'd be a good idea to dive into some of those details now to see what all is required there.
Matt, does the proposed rule alter current DEA controlled substance practice location registration requirements?
Yeah, so we're likely going to see some additional clarification here. But what is proposed is that the practice needs to have DEA registration in both the state where the patient is located, and also where they are physically located, regardless of if they see any patients in that state. So if you sort of think about a virtual operation, maybe you're, seeing patients in all 50 states as an example, you would have to have registration in all 50 states. If you are, seeing patients and they're not in the state where you're located, you have to have the registration in the state where you're located and also where you're seeing patients. So this was also covered in the proposed rule.
Matt, how is the DEA aligning with the Centers for Medicare and Medicaid Services, CMS, around using an audio-only equipment for mental health disorders?
Yeah, so we touched on this early on. So the proposed rule does align with CMS around some of the exceptions for mental health. So in mental health, the patient can be at home. You can use audio only technology if the patient consents to that or does not have access to the technology. And again, there are some documentation requirements around that. So you do want to review that, make sure you're documenting that accordingly. And then it also aligns with CMS in that the practitioner has to have the capability to do both. They have to have the capability of audio video, but the patient, if they don't have access to the technology or they just prefer audio only, they can make that choice as long as you document that appropriately. So they're really just aligning with CMS here.
Can you explain, Matt, the separate rulemaking notice for buprenorphine and how it relates to the buprenorphine patients and its relation to the proposed rule?
Yeah, so we'll just touch on this briefly because I know this won't affect everybody, but when the proposed rule came out for in-person visits regarding telemedicine, there was a second proposed rule for buprenorphine. So it's likely we'll see some exceptions related to this. So that was a separate proposed rule, had a comment period, and we'll see a final rule related to this as well. But it is likely that we might see some exceptions related to opioid use disorder. So if that affects your organization, you can dive into those details.
Matt, can you explain, we discussed earlier about, well, really all this webinar about how it impacts federal. You started talking about state. How do you see how the state and federal laws interact and how practitioners must be complying with both?
Yeah, I think this is where things can get a little confusing, but to just simplify it for everybody, you have to go with whatever is the most restrictive. So if the federal law, the Ryan Hate Act, is the most restrictive, that's what you have to go off of. If your state has further restrictions, again, we talked about the Center for Connected Health Policy website. That's a great place to stay on top of your state rules and regs, especially prescribing. Most states have laws around prescribing controlled substances. So if there's anything in regards to a particular state, you can find that on that website. But to just make things simple, basically you have to follow whatever is the most restrictive.
The proposed rule was open for comment, and Matt, we discussed how there were a lot of comments. What's an example of some of the comments that you were seeing that illustrate how these changes might impact the final rule?
Yeah, so lots of organizations commented. So these comments here on this slide aren't the only comments. Given that the AMA is in charge of a lot of CPT codes and whatnot, what are the types of things that we might see in a final rule, right? We already got a glimpse that maybe there will be an extension to November. Here is how the AMA commented. Again, hope for the best, prepare for the worst. These are some things that we hopefully will see. The AMA commented on the buprenorphine, so extending that time frame to 6 months instead of the 30 days for that particular treatment, and then also suggested the ability to get a 6-month prescription instead of a 30-day, right? We covered the 30 days. They're suggesting move that to 6 months before having to be seen in person. Maybe we'll see that change in the final rule. Let's see here. Instead of no Schedule 2 for telemedicine, the AMA is saying, look, and I mean, there's already sort of exceptions that I think in mental health and buprenorphine. So they're saying, hey, let's maybe there are some use cases that are important, and there should be other Schedule 2 exceptions added. So that's part of their comments. They also want to remove some of the administrative burdens around record keeping that we talked about, especially in this telemedicine referral process. And then they're talking about stricter enforcement for the outliers, right? I mean, it seems like, this is just the way government seems to operate. We could have some bad actors, so let's make everybody suffer. And there's always still bad actors anyway. So they're saying, look, let's create more flexibility for everybody who's behaving, and why don't you have stricter enforcement for those that are outliers? So this could be a good approximation for the changes that we'll see in the final rule, and hopefully we'll see that on May 11th.
Before we move on to the Q&A portion, let's do a quick recap of today's webinar here, Matt. So in-person requirement is back in effect unless there is a documented telemedicine relationship established during PHE. Telemedicine prescriptions require specific notations for virtual first and qualified telemedicine referral only. Practice must have a DEA registration in both the patients and their own state, regardless of whether they prescribe to patients in their own state. Practitioners must comply with state and federal laws. As you pointed out, whatever's going to be the most restricted. Further clarification needed on DEA state-by-state registration requirements. And the proposed rule allows audio-only consultations for prescribing controlled substances to treat mental health disorders in specific situations. Anything else we're missing? Highlights for today, Matt?
I think those are the keys, and we'll likely see a final rule here shortly. And when that rule does come out, we will definitely have an event. Whether we do something quicker, depending, if there's an extension period, we'll schedule an event. But as that rule becomes final, we will definitely have another live event and get that information out to everybody.
Matt, given today was all about recent regulatory changes impacting telehealth, explain a little bit for the audience that doesn't know about Men's platform, how it approaches telehealth differently.
Yeah, I think, to sum it all up, I think a lot of our customers agree that, Mend is good at making the visits happen. More visits seem to happen on our platform. The no-show rates are lower. And really, we've just removed as much friction as possible from the patient's perspective. They get a text message, an email, they click a link, they put in their date of birth, they're in. We have an edutainment type experience while they're waiting. So we have lots of helpful content in our enhanced virtual waiting room. And then if they have any issues connecting, we have tech support that's available within seconds. So this is a great way to become compliant, have an integrated HIPAA compliant solution that's just effortless for patients to connect.
That's to be expected, Matt. A great rundown. For those in the audience who may not know, Men doesn't just do telehealth. It's a complete patient engagement platform for in-person, for virtual, for any type of patient visit. Matt, how does Mend help patients and providers? You will kind of touch on some of this, but in the beginning of this flow, how do they end up all the way to the end of this flow where we see this happy person jumping at the end?
Yeah, I mean, we've been talking about, virtual, in person. We've got groups of satellite locations, groups, social workers going to people. The appointment type does not matter. So as organizations have to begin to think about in person again with some of these new proposed rules, we can put all of that together. So patient self-scheduling, appointment reminders, the ability for patients to make changes to their own appointments, all the paperwork that needs to be done, any payments that need to be made before the visit. Then we can actually facilitate the visit through telehealth, through kiosk modes. So we can host the visit, and then we can accomplish anything that needs to happen after the visit. So we might need to get surveys out there, push people to reviews. Maybe we still have some outstanding balances. We have automated patient payments that can collect those outstanding payments through text and email. So end to end, we can solve all the patient engagement needs, whether that's virtual, in person, or any other type of appointment that your organization may have.
All right. If you're looking for more informative content like this, we keep a library in the resource section of the Mend website. This is actually where you'll find the on-demand version of the February webinar. We discussed how the omnibus bill impacts 2023 telehealth policy. We'll also be sending a direct webinar recording link of that webinar to everyone who's registered today, plus the recording link from today's webinar. But you can go over to there to check out all the great resources. Simply navigate to mend.com, click on resources on the navigation bar. And as a little preview of what's coming up next month, you won't want to miss our exclusive live webinar in May, where we'll be addressing critical issues such as the new AMA telemedicine codes, their potential repercussions on reimbursement and parity, the elimination of telephone codes, and unveil key insights from the ONC data brief on telemedicine usage and office-based practices. To register for that, if you go to resources in the top navigation, you'll also find it. You can click on to register for next month's live event right now. Matt, I give you a few seconds before we jump into the Q&A, and I'll start looking through the questions. I know you wanted to comment about this upcoming event, so go ahead.
Yeah, I just want to call this one out because I don't want the legal jargon to not make this clear. Parity relates to equal payment for virtual care. So that's equivalent payment for virtual care to equivalent services in person. These new AMA codes that would go into effect in 2025. So there's still time to be heard on this. The these new codes open the door to reimburse less for telehealth. We don't know that that will happen, but it's a big change to for potentially replacing certain codes that have been used. So I think this is an important event. This is an important area to be educated on, to stay involved on, and to maybe even comment on. So definitely make sure that you go to men.com. We have a little banner at the top. You can register for this event. This is an important one, and we have time before this could have negative consequences.
All right. The webinar's been amazing. Before we jump into the question and answer portion, just want to let everyone know it's easy to schedule a personalized demo of the Men platform. Just go to men.com/demo. And with that, Matt, let's jump into the questions. As a repeat for anybody who may not have heard earlier on, I saw several questions referring to the slides, the recording. Will those be given? Yes, for everyone who's registered for this webinar, you will receive in whatever email that you use to register the slides, the recording, and a few extra things that we believe will be useful as it relates to this topic. Matt, first question I see here is related to the 93 modifier. Is CMS using this with audio only codecs? And I won't read that long one. I'm sure you can see it on your screen. Their visits are not mental health visits.
Yes, so I'm just looking over here on my other monitor where I have this information to reference for you. So yes, you have the 93 modifier. That's for audio only. So that's for mental health and non-mental health. So that's the modifier. The only other audio only modifier is there's an FQ, which relates to FQHCs and rural health centers. So the 93 modifier should be the correct one. You can also reference Center for Connected Health Policy if you ever need to look at it. They have everything billing, coding related to telehealth there.
This is next question. They're asking, so we talked a lot about how this is going to impact telemedicine for patients. If they're seeing a new patient in person, will there be any issue doing telemedicine after?
It doesn't appear like there would be an issue. I don't know if there'll be some time constraint on that. If it'll be in person once a year, or you just have to see them once and that's it. that's kind of the way that things look, is, once in person, and that's it. But yes, effectively, if you saw a new patient in person, you could do telemedicine after that.
What if the patient is traveling at the time of the telehealth visit? Not quite certain if that's traveling in general or crossing state lines. But why don't you speak to it generally, and if this person, Ellen, can specify, we can come back to it if we have time.
Yeah, I mean, this is something probably to connect with counsel on. Some states have relationships with each other that do allow for some travel. But then you have other situations where maybe people are snowbirds, and that could create some potential roadblocks, given the way that some of the laws work, because you are supposed to be licensed in the state where the patient is located for the visit. And then, we've got the DEA, the proposed rule, at least saying the practice has to have a DEA registration there. So there's probably a way to navigate that, but there are some potential complications that you would want to look into. But there could be some good news. There could be, some relationships between the states that allow it without having too many additional hoops to jump through. But that could potentially be an issue.
Laura's asking, can you please give more information, Matt, on the end of the PHE and how it relates to RPM, or remote patient monitoring?
Yeah, let me circle back to my notes. So basically, you have the end of remote patient monitoring co-payment waivers. So that could be maybe co-pays that got waived, or deductibles, or other things that got waived. That will come to an end after May 11th. And then the other change relates to established patients. So there were waivers allowing new patients to be seen through remote patient monitoring, billed for remote patient monitoring. That is moving back to established patients for remote patient monitoring.
Here's a question from Jacqueline. Matt, most of this webinar was about the DEA proposed rule, which was covering prescriptions and how it relates to telemedicine. Does this proposal matter if we do not prescribe medicine? Jacqueline's asking. We just perform routine mental health outpatient services of therapy. Do they basically just need to make sure they're using HIPAA compliant platform?
Yeah, that sounds accurate to me. If you're just performing therapy, not prescribing, then probably not going to be any issues staying 100% virtual. But again, I would just confirm that with counsel, check state laws to be sure. But they're probably not going to have too many issues there if you're not prescribing.
Tiffany's asking, are consents for telemedicine visits required?
Yeah, I mean, consents can be required in certain states, but as a best practice, we've always recommended to have a telehealth consent. We give boilerplate consents to all of our customers. It can just be a click to accept it. So I would say, as a best practice, there's no reason, you with technology, you can make it pretty easy to agree to these things electronically. There's no reason not to protect yourself, not to protect your organization. It is considered to be a best practice. Not only that, some states may actually require that you get a consent.
Dawn Marie has a couple questions. Matt, I'll answer the first, and if you wouldn't mind helping me with the second. The first, she was asking that she doesn't see, they don't see the May webinar in the list of webinars. So we are going to put that on the webinars page. For now, if you go to the website, men.com, it should be as a little header bar up at the top. If you also don't see that for whatever reason, have no fear. By tomorrow, we should have that up on the webinar section as well. And we'll be providing a link to it along with the slides for later today. And then for the second question, Matt, Don Marie asked, my providers have patients in Oregon and Washington, and they have a clinic close to the Washington border. Do they need a DEA? She asked, do they need a DEA in both states? Probably referring to what you were talking about earlier.
Yeah, again, you could confirm with counsel, but it does. And we're supposed to get additional clarification about that in the final rule, but it does, the way the proposed rule reads, that yes, that is a requirement that you'd have to have it in both states.
Ellen is back with a couple of other questions, referring back, Matt, to when she was asking about if the patient is traveling at the time of telehealth. Apparently that had to do with referring to prescriptions. Any difference in how you would answer that if it was referring to prescriptions?
Yeah, I think the answer still stands. I think especially if you're prescribing with this proposed rule, you may have to have a DEA registration for the practice in that state. And the provider is supposed to be licensed in that state. Everybody's got to get their fees. So I think that's, I don't think much changes there beyond, if you're prescribing or not. Other than, if you are prescribing, then the DEA is saying you need to have, your practice needs to be registered in the state as well.
And then Ellen had another question. If you could elaborate on the documentation requirements for audio-only behavioral health services. Does the patient have to be located in their home for audio-only as well?
Yeah, I'm not sure of the exact specific documentation requirements, other than I know that there has to be some documentation around if they don't have the capability or if they elected for it to be audio only. So I don't remember the specifics off the top of my head. The Center for Connected Health Policy, that website, and we'll send that out to everybody, should have those specifics. I wouldn't be too concerned when we talk about the patient being at home. The home is usually sort of defined as home or home equivalent. They don't actually have to be in their home. That basically just says, they don't have to be in a designated rural facility, the home or a home equivalent, what have you. And the definition of home does seem to be expanding a little bit, but I wouldn't get too concerned about that just kind of suggests that they don't have to be they don't have to be hosted in a facility. They can be virtual.
All right, Matt, we're coming up on time. Try to get through one or two more questions. Amanda asks, what about coverage plans? They work in an outpatient clinic, and when providers are out of office, others cover and refill medications as appropriate. What are the guidelines or recommendations for this with prescription controlled substances without an in-person visit?
Well, if it's an outpatient clinic, it almost sounds like there would be some in-person potential there. I'm just trying to read the question, but it wants to know about prescribing without an in-person visit. I mean, you can prescribe, right? The rule says you can prescribe 30 days. So you can prescribe. It's not saying you can't. It's just saying that, then you'd have to have the in-person visit within 30 days. And then we've got the AMA wanting to extend that to 6 months. So you may have even longer. So I would imagine that is probably something that can be handled.
All right.
And it looks like there was just a quick follow-up. The patient has been seen in person by another clinician. Yeah, if it's within your practice, you've seen them in person within your practice, then other providers could do telehealth. I think it's really when you're having different organizations, that's when that telemedicine referral process comes into play. If you're going to partner with another organization for the in-person visit, it's sort of like if you make a referral in healthcare, right? You're referring to another organization. But if it's within your organization, again, you would be a good thing to just talk to legal counsel with, but I don't think there would be any problems with that.
All right. That brings us to time. Matt, thank you for answering all those questions. Thanks everyone who's still on for tuning in, joining Matt and me today. It's an honor discussing this with you, Matt. And for everyone else, we hope you can tune in next time. It looks like we're going to have a great webinar on May.
Thanks, everybody. Have a great day.